Good morning, everyone. Welcome for another session of Peripheral Interventions from Mount Sinai Hospital. Today, December the 14th, I, Vishal Kapoor, welcome you for another case, our last case of the year. Due to the holidays, we had to prepone our schedule. Hope it wasn't inconvenient to watch us live here from the Mount Sinai Cath Lab. Just before we go over to the Cath Lab, a few basic errands as ever. Our cases from the previous sessions are available on the archives at peripheраlinterventions.org. You can email us any comments, questions during this live case at info@peripheраlinterventions.org, and we'll be more than happy to discuss and respond to your queries and take your comments. For our next future broadcast, it will be on January 25th, 2017 at 8 o'clock from Eastern Standard Time. All right, so I guess we'll now just directly go to the Cath Lab with Dr. Krishnan and his team and watch the live case. Morning, PK.
Well, good morning, Vishal. Thanks so much again for moderating this session. We are really happy today to have a great case. Unfortunately, it wasn't the case we planned, but due to medical issues with the patient we had planned, we had to make a last-minute change, which we were able to do. We still have a great case, a lot to learn. So again, to my right is Dr. Karthik Guja. As you guys all know, he's been with us for almost every single one of these for the last few years. Dr. Farhan Majid, who's our endovascular fellow. Ray Lascano, who's our interventional NP, endovascular NP. Elizabeth, who's our endovascular nurse. And we've got Damien Cabrera, who's our endovascular tech. So we've got a very good case here with a lot to learn. So I'm going to ask Farhan to go ahead and present the case.
Thank you, PK. Good morning, everybody. So our case today is a 87-year-old female who has a history of diabetes, hypertension, and hyperlipidemia. The patient actually presented with significant lifestyle-limiting bilateral lower extremity rest pain, left greater than right, over the last 2 to 3 months. Rutherford grade 2, category 4, Fontaine stage 3. The patient's pain was so significant over the last few days that she actually went into the emergency room for pain medications. Anyway, we brought her here. She does not have any ulcers noted, and she denies any other complaints. Next slide, please. Her past medical history is significant for diabetes mellitus, hypertension, hyperlipidemia, and peripheral vascular disease with rest pain. Next slide, please. Current medications include aspirin, 81 milligrams daily, cilostazol, 100 milligrams POBID, losartan for her blood pressure, as well as Lasix. She's on Crestor for her hyperlipidemia and metformin for her diabetes. She's not allergic to anything, not a smoker, not a drinker. Family history is negative. Review of systems is otherwise negative. Next slide, please. On examination, her blood pressure is 130/70, heart rate is 82 beats per minute. Her cardiovascular exam is unremarkable. Her extremity exam reveals that her pulses are significantly diminished bilaterally in the DP and PT, and she does not have any ulcers. Her laboratory data shows that her hemoglobin is 12, platelet count's 170, and a normal creatinine. Next slide, please. So she had a arterial Doppler ultrasound that showed extensive atherosclerotic plaque bilaterally. She had abnormal monophasic waveforms with evidence of hemodynamically significant bilateral distal SFA disease. Next slide. So in summary, this is an 87-year-old female with a history of hypertension, hyperlipidemia, diabetes, who presents with significant lifestyle-limiting bilateral lower extremity rest pain, left greater than right, over the last 2 to 3 months. She has an abnormal arterial ultrasound with monophasic waveforms and significant distal SFA disease, and she was referred for a peripheral angiogram. Next slide. Thank you.
So that was great. That was a great presentation. So when you see a patient like this with rest pain, I just want to ask both you and Vishal, Karthik, on what would you guys expect angiographically on these kind of patients who have rest pain?
So usually when they have rest pain, I'm assuming that the flow is, if you compare to coronary versus peripheral, in coronaries we say TIMI 1, 2, 3 flow. We're talking about TIMI 2 or TIMI 1 flow. That's when they usually have rest pain. People can't just have rest pain with 70%, 80% SFA disease. When you see rest pain, now you're talking about a critical limb situation. So I'm talking about a CTO in SFA, or you're talking about a popliteal CTO, or a severe iliac disease, which is almost like iliac disease, or you're talking about severe 3-vessel intrapopliteal PAD, or with no flow to the foot.
Right.
That's what I would think.
So Vishal, how about yourself?
I think pretty much the same way. I mean, when you have rest pain, it's probably multi-level disease is what we are suspecting or looking at. You'll probably have an SFA lesion which might be significant, critical, or total obstruction, in addition to you having a below the knee vessel. So it's both an inflow, outflow problem that really presents. So there has to be a significant compromise in flow. So I think both above and below the knee, you generally suspect to find a combination of both diseases with poor flow causing the patient's symptoms.
So let me go over the angiogram. I think these are great points that you guys both make. So you can see here that the angiogram obviously shows that. So this is our rough. Let's start with the iliac. The right leg had a little bit of disease. So this is your aorta iliac shot. So you can see that aorta iliac wise here some moderate diffuse iliac disease. Excuse me. And then this is your superficial left lower extremity angiography. So you can see here the left lower extremity angiography shows an occluded SFA with an occluded with the patent profunda femoris. And then you can see here that the SFA is actually occluded all the way to the adductor canal over there. And then you can see that below the knee or at the level of the popliteal, there seems to be another stenosis versus underfilling right in that spot. It's likely underfilled over there, followed by either an occlusion of an anterior tibial artery and I think maybe 2-vessel runoff into the foot, which again, we're not sure. So with this, would you expect to have rest pain in this kind of patient?
I mean, it's definitely a possibility, especially the degree of stenosis with not adequate blood flow through the profunda collaterals. And again, below the knee vessel issue as well. It's definitely likely that the patient would have rest pain.
Well, so it's interesting. So when I saw this, what was interesting to me was that it was more the history that was really interesting to me. So if you see, she's got a really progressive pain over the last 4 months. So I'm thinking that she probably had a severe stenosis and then has progressed onto rest pain because of either thrombus formation and distal embolization in the SFA. So it's very, very important here when you start planning these lesions of a CTO of an SFA to really look at it. So Karthik, I mean, maybe you could talk a little bit about the elucidation or the mechanism of SFA occlusion that nobody really understands it. Of course, it's atherosclerotic based, but what do you see in your own practical experience in terms of in this kind of patient, in terms of the type of atherosclerotic debris that you might find in there?
As we normally see, PK, right? It's significant. So, I mean, you can see here that she has calcification and everything. So her progressive disease, as you said, I mean, I don't know if I would completely agree with the thrombus formation part. I mean, yes, if she has a progressive CTO, I mean, it depends on how the wire passes through. We can realize how much amount of like hypernating vessel there is. I would say like SFA has hypernating vessel. So if you have a total occlusion, probably the total occlusion part is somewhere a little shorter, 30 to 40, and everything else is probably hypernating. We might be able to traverse through that hypernating vessel very easily. But this looks like a diffuse disease. As I said, we're counting the frames. We have like 10 frames and then you still don't see the flow in the tibials. That's what I was talking about the TIMI1, if you count it on the legs. This is a rest pain leg. So.
Right, so you can see here, Vishal, you have some calcification. So I think when everybody looks back and sees this, when you start to approach these lesions, what are the parameters that the two of you are looking for when you start to cross these lesions? Because we get asked, often asked this question, how do I cross a CTO efficiently and safely? So I'm curious on the two of you on what are the parameters that you guys look for before you cross a CTO?
So, well, if you look at, so in this case, calcification is both a guide and a hindrance as well. It gives you a good marker of where your vessel is traversing, going down, or like a pathway, but at the same time, it will cause you a lot of troubles getting you into the subintimal planes, getting your devices and everything down. So cases like these where you actually have some stump, if you can see in this case, the proximal segment is a little bit patent, at least, you can start, my approach will be to start with a less, I mean, some people love to use the reentry or the CTO devices. That's another option. It depends how comfortable you are, what you have used and all that stuff. And if there's a collateral branch or not, but otherwise, if you want to go with a plain wire catheter technique, I usually start and usually step up my goal, starting with an 014 stiffer wire, and then going up to an 035 glide wire if need be. But with the reconstitution there, I think it's a high likelihood that we should be able to be successfully do this case.
Karthik, any other comments from you? No, don't go for it.
The best part about this is you see islands of SFA, right? So that tells you that you can get through to at least to the second island without a problem with the wire traversing through. That's what I was calling the hibernating vessel. This is all which you are thinking is probably thrombosed over time for the 4 months and then happened. So these islands will tell you that you can be intraluminal most of the time. So you might be able to cross all these SFA until the mid SFA without any crossing device. I think our true CTO is only like 40 to 50 in the distal end, which is calcified.
So I think these are all great points. So for the audience out there, to really be efficient and avoid complications, do things faster, what you want to do is when you start seeing this, you want to take a catheter down there. When you take a catheter down there, you want to go ahead and actually inject through that catheter. So when you inject through that catheter, it's going to show you a lot more than maybe you want to see. So you can see here, so we took a catheter down. This is just the stump. So you can see we take a catheter down here. Well, we're not there yet. You can see here's the islands of SFA that Karthik is talking about. But I just want you to see one thing with the catheter when you inject. So this is all through the catheter. Now you can see the level of thrombus that's actually present in this SFA. So remember that when you have a change in symptoms, there's got to be a reason why this patient went from a claudican to a true rest pain. I mean, she went to our local hospital, our sister hospital, St. Luke's, with true rest pain, and we were called, and they told us that we were doing this. Second thing is, now when you've done this, you also can start to plan your case. So two things are going to be there. One, like Dr. Good just said, we can easily, likely cross this lesion. So you can actually predict your choice of wire. So without noticing the islands of the SFA, I mean, most people would have taken a 035, and you may still have to go with an 035 glide wire. But generally speaking here, you might want to take a finer wire, try to, wire your way down. Again, cardiologists get all this craziness about 014 wires in the SFA. And, to me, I just have never really liked 014 wires other than to really re-enter or to, do fine movements in the SFA. I think that an 018 wire is probably the wire to start with. It gives you the body, the pushability, something like the Connect 250T, and then go ahead. Second is now as you go ahead, now you can do it on the roadmap, you don't have to do it on the roadmap, but in some way you need to know where you're going and then probably figure out as you're going whether what Dr. Gujja and Dr. Kapoor said, that you're going to have an area of occlusion may be true. So what we've decided to do based on our study of the actual angiogram is to go ahead and put a directional catheter down there, and I want to show you a directional catheter. It's just a simple cordis aqua tempo. Just give me a roadmap. Thank you. Aqua Tempo vert tip catheter. It's like a $40 catheter before you break out your devices. Then you just want to inject just to really see where you are. And you can see that's the area of thrombus that you saw before without a question. And then you can see at least to that part you can get to. So give me the, so we're going to go with this connect wire that Dr. Gujja and I like. And what we're going to do is we're going to try to wire this down. And do this. So as far as wires, any particular wires you guys like better? I know there's a plethora of wires in terms of what you guys, I know Karthik, you work in the OBL with multiple different wires than we have here.
As you said, PK, I mean in the OBL, cost becomes a big factor. As you just said, I don't use an 014 wire in the SFA at all. If it's a CTO, I directly go to the 018 wire because it helps me save, the cost on the 014 wire and everything. At some point you have to, but it gives me an idea of how much equipment I can open up if the 018 fails. So
Vishal, anything for you,
I think is starts with an 014, right, Vishal?
No, I mean same thing. Like I said, I mean this was all before we saw that thrombotic lesion. So usually try to find if there's a micro channel and like you said, an islands in this case, you could try to remain intraluminal. And then the 014, 018 gives you a little bit more flexibility on that part. And if it doesn't traverse through, then of course we have an 035 system to help us guide through and just push across the lesion and get back with that. So
we took this catheter down to where we wanted to go, just regular cylinder, just regular. So now remember that one of the things you don't want to do is inject and stain. Right. Now, this, I mean, obviously we're being really, really patient here, but it's still only 20 minutes off-road map. So we've been yapping away. So what we're going to do is we're just going to pull this catheter back till I get some blood flow, okay, which is right there. I'm starting to get some blood flow, right? I'm going to keep pulling this catheter back a little bit until I get some vigorous blood flow, yeah, which is good right there, right? I got some good, not really. So now what I'm going to do is I'm going to road map from above rather than inject through this. So ready, guys? Give me a road map, mag up a little bit. Okay. Let me just That's good right there. Good. Roadmap. Go. So it's worth an attempt to try to wire it normally, okay? And then you want to see whether you can go ahead and try to get down distally. And you can see you really can't even see your distal reconstitution as of yet. Right. So, but you can still see there are some islands of vessel that are still patent. So I'm going to keep going with this 018 wire and try to get down there. And maybe now, because of the fine torqueability, I'm going to ask for a Confianza or what are those Asahi peripheral wires? You have the Gladius, and you have the other one. What's the other one called? Damien, the Asahi peripheral, Gladius, and one more.
PK question. I mean, once you cross this with all the and Vishal, you do the same thing because now I mean as PK ejected and he's right, there is thrombus there.
Is there anything? Oh, Halberton, yeah, that's the one I want.
Would you go forward with a thrombectomy or something like that to do it?
It just depends on how you close and then what happens after you get done. I think for sure I'll use a filter here now, and probably I would not do a thrombectomy because it's not acting like an acute thrombotic lesion. Okay. So I probably would not do a thrombectomy here at this stage. So I switched out to this 018 Halberton wire. It's an Asahi newer wire that we've gotten in our lab recently. Seems to work really, really well. Now remember, you have to have a mental time frame and how long you want to waste your time on an SFA CTO. I mean, the bottom line is this should be a 25 to 30 minute case. In generally in our hands here at Sinai, all of us will cross this in 25 to 30 minutes from in terms of the whole thing, and then finish the case. So you don't want to sit here and waste too much time. But I think it's time to at least analyze what your angiogram is showing you and understand what are the things and the take-home points that you can take. Okay. So you can see here. Here's the Halberton wire. Again, very, very stiff wire. Okay, coming down, sort of, not in a good way. Give me a torquer here. I mean, it's going down the right area. I like that. Okay. We'll just do this for a few minutes, and then we'll flip out to decide what else we want to do here.
Vishal, when would you just change it to like a crossing device or something? How soon do you switch, Vishal, in your practice?
For me, I mean, if it's just a plain old stump, I mean, this case, like you said, has multiple islands and everything, so I would probably just do the regular wire catheter technique. But let's say if you have a proximal stump, which is like a beak-shaped favorable, I usually try to at least start and get a feel with how the crossing device works. And if it goes way off track, then if you pull back and go to your old school basics. But in this case, I would not be a big fan of using crossing devices because it'll go in and out. And here, I would probably want to have a feel of the wire to see how my wire is behaving and moving, whether it's going out, going in, and whether we're connecting those islands. So like PK is doing in this case, I would just probably go the wire catheter technique right now.
Yeah, I think this is a wire catheter technique case here. Let's come down here and see where the F we are. Let's take a picture here. Ready, DSA?
PK, do you have any tricks or tips for people to know if you're within the vessel, without the vessel, besides just the feel of the wires?
I think honestly, I think the SFA, you have to be aggressive here. You have to kind of see where you're going and which way you're going. Here, obviously, so you can see how you're on top of the vessel on that one spot, and then you're coming back down. So I'm gonna come down to that area there with my catheter. Hopefully, if I can really shove my catheter down there, and then see I'm coming down at this spot here. So now I'm going to come back up a little bit, and I'm going to try to re-torque my wire into this vessel if I can. And sometimes you can get in, sometimes you can't. That's going somewhere it shouldn't be going. And the whole thing here is you really kind of, you can tell by the movement of this wire that it's not really in the right spot. And this is where you said, Vishal, the calcium really hurts you because you could see the subintimal calcium here is really hurting me. It's really giving me a hard time. You can see I'm bouncing off this calcium here, going in different areas, right? I'm probably dissecting down here. So I think what I want to do here is mag up, give me a torquer, and I'm probably going to go with a little stiffer wire because I'm closer, right? I'm going to,
Is there any thought process behind using an 035 support catheter instead of an 018 support catheter?
There are fantastic 018 catheters. My idea of going with an 035 here is that I can just switch out immediately and go with a a different wire if I need to. So you can see here, it looks like I may be in the spot here. I'm not sure, but it's definitely not moving like I am. But we'll see where we go here. That's definitely not it. That's definitely not it. You can see here we're definitely not in the right spot. So sometimes, show me above. Sometimes you just have to bite the bullet here and switch out to an 035 wire. Generally speaking, this level of calcium is really, this is the reason why I really don't go with my wire's tip is ruined. You can see it here. Yep, you can see the tip is ruined. All right, guys, give me a glide wire here, angle glide. So now what we're going to do is we're going to switch out to an angle glide. And so far, you could have said, people would have told you just go with the glide wire to begin with, which I don't think is the wrong thing. And because of this level of calcium, going with an 035 wire may not be the bad thing to do. So, a little load mag, yeah. So I'm just going to pull this catheter back a little bit. And then I'm just going to go ahead with the glide. You can see the glide is obviously very violent wire, does whatever it wants to do. And the issue here becomes as well, are we just going to take a loop here like that? So this is kind of like the loop entry technique here. So we're just going to take this catheter down, and then we're going to leave it there, and we're going to have Karthik mag up here. And we're just going to go ahead and just quickly re-enter. Roadmap here. Let's get an IBIS set up, guys. Roadmap.
IBIS.
Go ahead and inject. Now, two of the things that all of us here teach is very, very simple, Vishal. As we try not to lose this this actual roadmap, what is it called, or this loop at this stage. So right now, what Karthik is we're just gonna slowly, see how it's going away now? See, that is a little bit of a problem. You see that? When that starts happening, then you gotta really start worrying that you're gonna get away to another area, and this might be a point where you might wanna lose the loop, because you definitely don't want to go there. You see how this thing is starting to go away?
Especially the loop starts to expand.
And the loop starts to expand.
Yes.
So at this stage, what you want to do is you may want to pull back the loop here, which we don't normally do, which I'm going to do there, and then just try to see how I redirected? Yeah. So I just redirected it back, which is very important because it's very calcified at that spot. So it's actually bouncing the loop away. See, so the whole thing is at this stage, when it's very calcific, what you want to do is really control your loop as much as possible. See that? Look how calcified that is. See, one of two things is going to happen there. It's either going to bounce away into the medial plane and get away from this, or it's going to go right down. So here we're right near the distal reconstitution zone. So what I want to do is, for teaching purposes, I just want to go to two views here to show you how close or how far we are. So since our creatinine is normal, we're just going to go ahead and do another quick road map just to see where we are. So you can see here when you do this, you can see you're moving a little bit away, but don't give up, meaning don't give up the loop at this stage. What you want to do at this stage is really just reduce your loop as little as possible, and then just slowly advance, and Ray's just going to advance my catheter. And you have to have a 10 mm zone distally in which you're going to say, I'm going to enter the vessel, right? So at this stage, hopefully Ray's going to advance here, right? I'm just going to reduce the loop again, okay? And then I'm just hopefully going to pop in here. I didn't get in, pull, go in late, right? Okay, I'm going to stop here and I'm going to lose the loop now. Okay, what can happen is the catheter, you see how the catheter whips in? So that's when you want the right choice of your catheter helps you to actually get there. And the second thing is you have totally been able to keep this catheter away from getting into the subintimal plane. I mean, getting too distal to the distal reconstitution. Guys, this does not mean you're in. I mean, you do not want to just inject dye here. So generally what I want to do is just loop this very, very carefully, like torque it if Ray would let go of the catheter a little bit for me. Oh, you're not on it? Okay, it's not moving at all. And then I'm going to try to just withdraw a little bit of blood, and I'm getting a little bit of blood. So now at this stage, what I'll do is I'll go with an 014 fielder wire, which I don't believe I'm in. So I'm going to go with the 014 fielder wire. So now remember, we have not taken this distal reconstitution zone into too far into the above knee popliteal. So if we need to use a reentry device at this stage, we can. So we're still preserving options. I know people say, well, do you really preserve any options when you do this kind of thing? I think at this stage you are definitely preserving options because you have not extended the reentry zone too far into the distal popliteal. What is your feeling on that, Karthik?
Yeah, I think I agree with that, PK. As long as you're not too far into the popliteal zone, I think re-entry is fine. I guess, if you don't have a choice, some people re-enter the popliteal, which I really don't agree. But at this point, I think this is very safe zone. You're talking about adductor canal re-entry, which is absolutely fine to re-enter.
And you can see I was right. See, I wasn't in. See?
Right.
See, that's the problem.
It's probably right on the vessel.
Right on top of the vessel.
Yeah, it's still spiraling now.
I'm definitely not in. I'm just going to move forward a little bit with this. And also, you're trying to re-enter in a very diseased area.
So, PK, how concerned are you in cases like rest pain and all for these collaterals which form the distal vessel of losing them while you're in the subintimal place?
There is absolutely no question, Vishal. You are very, very concerned. Give me a comprehensive here, guys. You are very, very concerned. You are very, very concerned. There's no issue. There's no question about that. So you see how far away we are from that collateral, and you can see that disease zone right there, which is actually, we're quite far away from that collateral. Give me a wire introducer.
I think you're right on top of the vessel.
We are right on top of the vessel. You're absolutely right. So the choices here. What would you guys do now if you're right on top of the vessel?
I'll use a stiff glide wire and try to see if it just pops through.
Okay, stiff glide wire and pop through up top or below?
Right where you are right now.
Show me above. Oh, I am there, okay. So what I usually do here in this stage is pull this back.
What do you need?
Go to the fatter portion of the vessel.
Yeah, and I just try to poke through with the confianza.
Okay.
So sometimes the 014 coronary wire will find its zone in. Now this is really,
yeah.
You can see that calcium. Yep. Show me above now. I'm actually going to come back up here. Okay. Go to lateral view, guys.
Watch your legs.
I think the biggest hindrance in all these SFA cases is mainly the re-entry part, especially with so much.
Well, especially when they calcify.
Yeah.
Now give me torque and some dye.
It really causes you all the trouble and the pain.
You see how far away you really are?
Yeah.
Very interesting. So we're probably going to need a re-entry device here.
Device right there.
No, we'll see. I'm just going to pull it back a little more here. Torque it the other way towards the vessel. Point it. See, this is where a directional catheter helps you. Yeah, I'm just sliding on top of the vessel.
Right.
Huh?
Right there,
Yep, I know. You're right. You're absolutely right. I'm just trying to poke. I mean, people would just go right into the re-entry device level here.
Right. That looks better.
I know it looks better, but unfortunately we're sliding.
Plane, yes.
I kind of do like this better. Huh? But it's exactly what I was going to do. So I'm just going to take the catheter down here.
I think it's all the issue between the distance of your catheter and the wall. So the farther away, it becomes even more tougher. If you're on top, like you said, you could probably pop through a confianza.
Yep, there's no question there.
I think this is a better plane. It looks.
It definitely is.
That's good.
Right.
Yeah, but I have no support here.
Yeah.
Get the catheter down there and that's
There.
No, we're out of it. We're probably broken to the vein here. Go to another view. It's always good to go to another view to see how far away you are. You'll be shocked. See? Road map, guys.
Yeah, it's deflecting off the road.
All right, let's get the Outback.
Yep.
Looks like there's a little perf there. Give me the 035 glide, guys.
Me and Farhan had the same case last week where we tried everything, including the Outback, but the calcification just really took us away.
What happened?
We had the same case last week where me and Farhan even tried the Outback, but the calcification just won't let us eat through. So
Really?
we just had to, bring
So
it
what
up.
are your CTO, what do you think are the advantages and disadvantages of all the CTO devices that are available? Let's turn off the Macs for a little bit.
Go to the top.
I mean, CTO devices are good to initially help
okay.
cross lesions where you want to, shorter segments to begin with. That's what I would practice on. But
Should
at
be
the end of
okay.
the day,
See?
still
Right on top of
a wire catheter technique that helps me do my cases. So
Yeah, that's perfect.
we're right there, yeah.
All right, give me the Grand Slam. So what about you, Karthik? What CTO wire did you do like?
So I usually cross with the connect as we did. I mean, if I have to really use a CTO wire or something, then I really use a Astrado. Astrado has a good tip and a blowed. I use that more commonly. I'm used to it, so I use it.
Do you use CTO devices in outpatient labs?
Only when situations like this happen. Outback, I use Outback most of the time,
Right.
and it's easy. Every other device we have basically has a higher French. So Outback can go through a 6 French and can able to cross through a 6 French. But again, you might want to avoid using an Outback as much as possible, because if you have a small perf or anything, it's easier to manage in the hospital than to be in the outpatient lab.
Right. So the Outback device, I think most of you know how it is. It's got a needle reentry technique to be able to go back in.
Check your
So we're going to go ahead and just we flush both ends of the port and then come in. Now, when do you guys change to pedal access in these kind of cases? Do you have had incidences when you can't get through with the Outback and you have to go to pedal access?
The only time I switch to pedal access is if if the CTO is too far into the proximal pop, and I don't have any other choice other than to re-enter into the pop. I never re-enter into the pop. I never use a re-entry device at the level of the pop. So then I go from below. If it comes to the level of the pop, then I just go from below. What do you think, Vishal?
Well, I mean, it's mainly about if once you start running out of options and you spend so much time and you've tried every wire technique to do, then I would probably change over to a CTO, either bring the patient back, unless it's a critical limb, in this case, which is, probably then switch over to a pedal access and try to enter. Entry into pop, I guess Karthik is a little bit more conservative. I've been a little bit more aggressive into entry into pop. I know people say you can have pseudoaneurysms and with the popliteal, which could be clinically significant, but if everything is in a controlled environment, you know what you're doing, it should not be a big issue. But again, you have to be cognizant and respect the popliteal vessel for sure.
So the only problem here is the plane too big, and we've seen that in the Outback in these very calcific lesions where it just bounces back on you. And that usually happens when the plane is too big. So let's see here.
So PK is doing this. I'll just explain how Outback works. Like PK is, what we do is whenever we have an Outback, right, we take contralateral views just to make sure how far we are from the vessel. That's why we did an AP view and a contralateral view. So we know now that we are right on the vessel. So we make a T shape. You might want to make a T shape and see the T shape. T shows you that you're right on top of the vessel. So that the straight limb of the T should be very parallel to the vessel. That's the only way you can know that you are re-entering the vessel right. The biggest problem with Outbacks or any re-entry device, as I think most of us know, is perf, right? You perf out of the vessel, it's going to be a problem. That's one of the reasons why I am very conservative in the
I don't know where we are, but we'll figure it out.
in the pop level, because I'm always concerned when you do it out of the pop level, you don't have enough
Just say this.
enough bone to give you support. So over time they can form aneurysms. So that's why I'm always conservative at the pop level with the reentry device. I mean, you and PK have more experience than I have, so.
I think we are intraluminal.
Yeah, we're we just got a nice loop there.
So push it down a little.
Just push this.
Before you retract the device, you have to get a little more. So here, Vishal, the biggest thing is before you retract the needle, you might want the loop to straighten out.
I don't think I'm intraluminal.
Yeah,
Because you can
Yes,
knot
I am.
up the vessel and then
Yeah.
you can have
So
it.
what happened? No, the reason is when you take like so we normally use any wire with floppy wires, right? So you can really cut off the wire. The wire can really cut off the Outback tip is like really sharp. So you can basically knock off the wire and stay there. So clearly we are in the vessel.
So we're clearly in a vessel in a branch. Okay.
Right.
So guys, so the most important thing here is obviously we prevented the wire from going too far distally, or the reentry point from going too far distally. Walk this out, please. Yeah, restart. So my question now is, well, how are you going to treat this patient?
Well, I would, first of all, my approach will be to put a filter down. I'm very conservative on the filter part. Most of the atherectomies,
given 035
even if there
trailblazer.
might be aspiration and
035
thrombectomy
Trailblazer, guys.
concomitant,
Actually, we can use the
actually,
no, we
018
can use
Trailblazer.
no, we can use the Aqua Tempo.
I would
Not
still
tear
be
through the vessel,
conservative
PK.
and put a filter down and then work whatever
Aqua
you decide on.
Yeah. Oh, Aqua Tempo, please. Yeah, I think we're probably going to use an IBIS. So I think we should do an IBIS first before we decide what we're going to treat with. Oh.
Watch.
So I think this is the utilization of intravascular ultrasound to tell you where you were, how far dissected you were. Because let's talk about the different therapeutic options for this patient.
So, just PK, I just want to make one comment about the Outback device. When PK was doing Vishal, I think everybody was watching it. He was very careful how he was directing the needle. He just doesn't like push the needle in. A lot of people I have seen over my past 4 years of my experiences, people just push the Outback devices. PK just push the device half in. He knows how much to control the device. You have to control the needle. That's the only way you can avoid any hematomas or anything around the vessel.
It's not going to go.
It's not going to go.
It's not going to go.
Because calcification,
Yep.
right? So given 018 Trailblazer, guys.
Give it 035 maybe.
I might not go.
Yeah, I agree.
018.
Trailblazer, a quick cross. And then
So Vishal, what would you do after crossing? What is the therapeutic options as PK was talking about?
But in this case, I would probably, first thing is I would put a filter down. And then I personally, if I would suspect there's a component of thrombus sitting there because of change in her symptoms or acute change in her symptoms. And also angiographically it looks a little acute and chronic thrombotic stuff. So I would not mind doing a quick aspiration run to see if I can get any of those possible clots out, and then atherectomy with
I think what we'll do is we'll do a quick IBIS, and then we'll take a look at what's going on. I definitely think there's a component of thrombus above.
Give us
I think that's going to help you with the filter.
Spartacor.
And if you balloon angioplasty it without putting a filter, I think you're clearly going to embolize. So I think everybody agrees that we're going to put a bare wire down here, which is an off-label use of the Abbott filter. I think the advantage of that filter in this particular area is that you're going to be able to use this, rail please. You're going to be able to use this and allow that wire to move while you're doing your atherectomy or whatever work that you want to do. And I think this is also going to help us direct, pull this out please. It's also going to help us direct the kind of therapy that we're going to impart on this patient. Whether or not you're going to do, give me some dye, whether or not you're going to do angioplasty and stenting versus atherectomy or not. Yes, just take a shot. So again, never ever be too cocky. Give me a DSA, please. Always check your distal vessels. Make sure that you're in the right spot. You know, you could be in a collateral or you can balloon into a collateral. There's nothing wrong here. We're just taking a second and just do a quick injection, you know, and then just take a look. You know, it's just going to let you know where you are, and you can see you're in a nice spot here. You can see very, very slow flow that Dr. Guja was describing, suggestive of you know, a lot of tension in the vein. So give me the what is it called, the bare wire now with a nice C loop on it, and let's set up the IBIS quickly. So once we get the IBIS, I want to go to a consensus on stenting, on what you guys want to do, whether you want a balloon angioplasty, atherectomy, or stent. And then based on that, what we're going to do is you guys are going to work on it. I want to go ahead and give my talk on the techniques of crossing CTOs and some of the things that are that could cause failure in this particular case. So here, this is a bare wire from Abbott. This is going in. So the bare wire so we have a nice filter landing zone in the distal pop up top. So you can see here, Dr. Guja is going to show me slightly higher. And then what we're going to do right there And then what we're going to do is we're just going to go ahead, and there's our bare wire going into the posterior tibial, which is fine. We know that's open to the foot, so I'm not too worried about following that. And it's got a nice safe C-loop. We're going to walk this out. Now give me the IBIS, guys.
Well, I would always recommend when you use a bare wire that check it personally, because your fellow might give you an 0-4 wire and the filter just distally embolizes and never comes out.
Yeah, we've had a lot of problems this year with our fellow.
They just had one.
We had to snare it out.
Well, you know.
Vishal, you had to do that to Farhan, huh?
I miss Farhan, so that's why it was.
You had to do that.
So we're going to go ahead. So that's actually a good point, because I think that's very important with this particular wire. If you're going to use this filter, you want to use the appropriate wire to be able to put the filter down, or else the filter will just move on its own and migrate all the way down to the distal pap. Yeah, you just happened to Vishal. So we're going to go ahead. Rail me, please.
Yeah, I have.
Pull the wire. Thank you. So we're going to go take the IBIS all the way down.
You have the wire, right? You have the wire?
Yep, I got the IBIS. So you can see I'm going to take the IBIS all the way to the distal pop. Okay, so this should be the vessel. So you can see, focus on the IBIS run, guys. Okay, so you can see the distal IBIS. So this is, put on ChromoFlow, please.
5 millimeter vessel, beautiful.
Chromo flow on.
Okay, so ChromoFlow's on, guys?
I don't see it though.
No,
Okay.
you put the virtual histology.
No, that's.
I'll do that.
So anyway,
You put the virtual histology.
You want pH
No.
or chroma?
so what this IBIS is going to show is what's the material inside this vessel.
Yep.
So we're going to go ahead now and start with a new run with hopefully ChromoFlow. There's ChromoFlow, I guess.
No,
I know it's not ChromoFlow, but I'm just going to start. You can see as I'm pulling back, you can see there's a lot of heavy plaque.
There it is. Chroma.
Okay. A lot of heavy plaque. You can see the calcium, and you can see I'm right around 5 was where we entered. And you can see this heavy plaque with a little dissection plane there, right? So now this is the distal vessel. Okay, now you can see you have actually 2 lumens with a flap. So this is the area where you've dissected very, very badly. Now you can see. You see how bad you. Now, what is that filling defect? Is that going to be a clot? Is that going to be just plaque?
That looks like a plaque.
That looks
but
like
it
plaque.
That looks like all plaque.
But are you in true lumen here? That's the question.
Yeah, I think we are
Yeah,
in the
we
true
are in
lumen.
true
It looks
lumen
like
there.
true lumen.
It looks
Yes.
like true lumen.
Say
I think
all the
only
way
in the
down.
distal spot where the calcification
See,
is.
it's all true lumen.
I think we are out of the
Look
lumen.
at that.
We're
We're
all
all
in the
true lumen
lumen.
here. Are we true lumen here, or is true lumen down below? No, we're true lumen. We're okay.
We are true lumen.
Yeah,
You see a color flow.
Yeah, we have a dissection plane below,
Yeah.
and we are truly, we're so far, everything is true lumen. We just have dissected in 2 different areas, and this is not true lumen here.
Yeah.
No.
See,
You
here
went
we're
to
not true
dissection
lumen.
plane there.
See, here we're not true lumen. And it's so funny because you would have thought that down below we were true lumen, but we're not. Down below we're
Now you're in the
down
true
below
lumen
you were
again.
in dissection plane, but that's what I would have thought. But down below I was in true lumen. Up top I thought I was in true lumen, but I'm in dissection plane. But here again I'm back in true lumen, and you can come all the way pretty much. There's the severe calcification here, out. Okay, guys. So I don't think we have thrombus, right? Everybody agrees that we are both in and out of true lumen and out of true lumen. So the question is, what do you want to do in this particular case to give this lady a reasonably durable long-term result?
You just do an atherectomy, do a DCB, and then if there's residual, then probably stent it if it needs to
Put
be.
the filter down. Give me a 4/7 embryosal. So, I'm so sorry. Well, I took the flu shot yesterday and it got me sick. What's your data to support atherectomy with DCB use?
Not much really out there. It's all more of clinical basis. I mean, the data on DCB and SFA CTOs and long lesion calcified is down there now, especially with some registries and trials with the patency rate first year at like around 83, 84%. But based on DART, yeah.
So let's look at some level 1 evidence. Do we have level 1 randomized evidence on using anything in these particular lesions?
No.
No. So what solid evidence do we have? Do we have any solid evidence, core lab adjudicated, multi-center, study showing that this may be useful?
We have one from Europe. We have one from Europe.
Which one?
Multi-center, the one from Belgium and Switzerland, no?
Which one?
What's his name?
Using, show me down, guys. So basically, this is the ambush shield going down. I'm going to place the ambush shield around here. Go ahead, Karthik, Mark. So Karthik's going to release the ambush shield. So basically, if you look at the data, the only data we really have is really with the registry, with the impact registry,
right,
and the silver long lesion registry. The silver Japanese PMA took on all comers, okay, with silver PTX. So again, showed reasonable, acceptable results in lesion lengths that were quite long at this length. Second is the impact global DCB registry. So the Impact Global DCB Registry, what do you guys want to do? Let's talk a little bit. Impact Global DCB Registry, so looked at what's it called, long segment lesions, ISR, as well as CTO lesions, and what they found was that there was obviously a reduction in TLR at 1 year. So we really don't have a lot of data, but this lady has rest pain. So as rest pain, I'd like to give her as much durable result as I possibly can in today's day and age. So in my opinion, in this particular case, what is the vote? What do you guys want to do? Vishal said atherectomy.
I would atherectomy and DCB most of the zones and stent the distal zone.
Okay. So one atherectomy and DCB with stent. So why not just use silver PTX all the way up?
The length of the silver PTX, right? You're talking about 250 millimeter stent now. I don't know the patency of those 250 millimeter stent, but we know from Impact Global data that with the Impact Global data that if you do DCB, your data is pretty good. Even if it's a long segment disease, I think it's pretty good. But still, I think they went only until 180, right?
No. The Impact Global had an arm greater than 25 centimeters, less than 25 centimeters. So greater than 25 centimeters, there was a drop off in patency.
Right.
However, there was a 40% provisional stent rate. So the logic for everybody at home is the only reason you do atherectomy here is you wanted to limit your stenting. So the technique of atherectomy is incredibly important in how you do the atherectomy, and then you can go ahead and do stent. So my opinion here is I mean, these guys want to do atherectomy, so I'm the old man in the room, so I'll give it up. What I would probably do is just do a DCB with spot separa here, just to be done with this case quickly. But atherectomy is not wrong, because I think as Vishal pointed out, the impact, the definitive AR, although it's a very, very small cohort, seemed to show some benefit. 10 patient cohort seemed to show some benefit with atherectomy in long lesions with DCB. So Karthik is just going to run the device down 2 or 3 times in a long segment. I think he bought the long nose cone one. Oh, you bought the short nose cone, 6 French up and over, because it's a small lady. And then we're going to go ahead and do the DCB. So you guys have all seen the Silverhawk DCB procedure. So I'm just going to go over my talk. Can you pull up my talk, guys?
Just a quick question before you talk. For people who don't have access to IBIS and you cannot really define thrombus versus no thrombus, would that make any impact on the decision of what kind of atherectomy you're going to use?
Say it again, Baya.
So what I was going to say is, for people who don't have access to IBIS and you cannot really define if it's a thrombus or not, would that be a factor in using any specific kind of atherectomy one over the other, or it doesn't matter?
Well, I think a lot of people here would tell us not to use atherectomy. I think we're a very aggressive atherectomy lab, obviously. So we tend to use a lot of atherectomy. A lot of people would say do not use atherectomy. In this case, just balloon angioplasty and stent, which I think is a reasonable alternative. So I think that we don't have much data suggesting that atherectomy is going to work for us here. Right. Can I have new gloves, guys? We're going to have much data saying that atherectomy is going to work here. But I think what Karthik's logic is, let's do atherectomy, debulk the lesion, and let's limit our stenting by preventing flow-limiting dissections because of our DCB balloon angioplasty. So let's start from above and do a couple of passes. Put up my slide set, guys. All right, so go back one slide. So let's talk a little bit about CLI, right? And why we fail, right? Back one slide, please. Okay, so approaches to CLI, what to do when convention fails. So you saw here, this is obviously not a classic CLI patient, but you saw a patient with rest pain with long segment occluded SFA lesion. So in this patient, obviously we wanted to do an intraluminal cross followed by balloon angioplasty and stent or atherectomy, and we failed. And we failed with our crossing. So let's talk about why you failed. Next. So if you look at conventional thing is what we tried. We said, okay, antegrade access, where we went up and over, antegrade access or up and over, we went up and over. We looked at the complexity of the lesion, we looked at the CTO, we analyzed the calcification, we crossed the lesion, and we treated. So this would be like an ideal case. Next, please. So this is the ideal case. Here's a lady we did. He's got an occluded anterior tibial artery into the dorsalis pedis, went down with a support catheter and a wire, crossed, balloon angioplasty, CLI, patient did well. Next, please. But what causes convention of flare? What causes failure of convention? It doesn't matter whether it's tibial disease or SFA disease. It's really multiple reasons. One is inability to identify the proximal cap. 2 is inability to cross the lesion. And 3 is inability to re-enter at the distal reconstitution. These are the modes of failure. Next, please. So what you next? Next. So it starts with anatomy. Next. So what you want to do is you want to do angle views. You saw how we did multiple angle views of both the proximal cap and the distal cap. We studied the cap in multiple areas and looked at which is the actual proper way to enter. So generally speaking, we did an LAO or an RAO. We used a shaped catheter, as you saw, a vert tip or an IMA. We looked at the calcification. Sometimes if you have a flush SFA occlusion or a flush tibial occlusion, you may want to use an external ultrasound to actually identify the cap. Next, please. So this is an example. This is a slide I borrowed from my good friend Sahil Parikh. Next, please. So you can see you have the front door, the side door, and the back door. So the front door is antegrade access, which is what we did here. The side door is you can either be subintimal, which we ended up doing here, and or collateral CTO passage, or back door is retrograde, which we talked about for this patient if we could not get through with the regular crossing device. Next, please. So now what causes inability to cross the lesions? Well, 1, you have a guide wire choice. Okay, maybe you chose the wrong guide wire. 2, do you have the right support catheter? 3, did you use appropriate angiographic landmarks? Or 4, your guide wire managed, but you're unable to cross the lesion with anything else. Next, please. So common crossing challenges, and this is regarding to the guide wire. So the guide wire fails to enter the lesion and buckles. You saw that happening. Second, the guide wire enters the lesion, but the body fails to follow and buckles. You saw that too. 3, guide wire enters subintimal space but fails to enter the tree lumen. You saw that through. 4, guide wire crosses the lesion but the device fails to follow. You saw that too. So you saw every one of the common modes of failure in this particular case. So my good friend Jahan Mustafa spent a lot of time analyzing these caps in order to come up with an algorithm, and this is really based on ultrasound to choose guide wires, which is really beyond the scope of this talk. So I'm just going to tell you that there are a lot of literature out there for you to analyze the CTOs and the caps. Next, please. So let's look at each one of the scenarios and see what we can do. Scenario 1, then I'll wait. So scenario 1, guide wire tips fails to enter the lesion and buckles, and we saw that happening. Well, what happens? Basically, this means that you don't have enough penetration power. The guide wire tip load is not enough. So what you may have to do is really increase the penetration power of the guide wire. Next, please. So potential solution is you can either increase the pushability with the same wire. Excuse me. Scenario number 2 is guide wire tip enters, but the body fails to follow. And you saw this when my wire seemed to be directing towards the SFA CTO, but it started to flip-flop, and Dr. Guja told me to take my support catheter down. And that's exactly what happened here. So the solution here is use a support catheter to go ahead and help support it, or go ahead and increase guide wire rail support and or decrease the friction by going with a hydrophilic coating. Take a picture, guys. Next, please. Next. So what are the common peripheral guide wires? And I think any good peripheral interventionalist needs to know his guide wires. So you have 014, 018, and you have 035, and you saw some of those guide wires used here. So you really need to understand all the guide wires have, you know, their pluses and minuses, and some of them are actually, you know, better in certain things and some of them aren't. So it's important for you to go through your own algorithm in terms of which guide wire it works best for you. So for us here, we used obviously the 018 guide wires, such as the Connect 250T, and we use some of the Miracle, some of the Ashai guide wires. Next, please. So the other scenarios, the guide wire crosses the lesion, but the device tip fails to follow, and you saw that. So here, what you need to do is, this is when our 014 fielder wire crossed through the Outback catheter, and then what happened was we were unable to track something, so we needed to get a smaller lumen catheter to track through. Next, please. So what are the support catheters? And again, I think this is important if you're going to do these cases in a quick manner. Let's do a DCB now, guys. What happened? The filter came back? Oh, pre-dilate. So you can see here the support catheters, all the companies have them, and I'm not going to say one's better than the other. I just think that you need to find the support catheters. So common ones are the Rubicon, the Quick Cross, the Bart Seeker, the Covidian Trailblazer, the Cook CXI, and the Terumo Navicross. Next, please. So again, this is the final scenario. The guide wire tip fails to enter the lesion and buckles. Again, you need the penetrating power to be increased, or you can use a crossing device. And this is what Vishal spoke about, was the crossing device. So next, please. So what are the crossing devices available in the SFA? So again, I think there's plenty of crossing devices. You need to get versed in the ones that make sense in your lab. You have the TruePath, the Crosser, the Front Runner, the Viance, the Ocelot, the Wildcat, Kitty Cat, so on and so forth. But as much as you want to cross, you may also want to re-enter. As you saw here, we couldn't re-enter. So you want to do the Outback or the Entier or the Pioneer Plus. It doesn't mean that you have to have all of them in your lab. You need to have one of them. Next, please. And here you can see the difference between an intraluminal and an extraluminal. The TruePath is supposed to be an intraluminal device, the Front Runner. And again, as you saw, all these devices try to be intraluminal. Some may be, some may not be, so we really don't know. Next, please. And again, this is the Reentry device we're talking about next. And you can see here the Reentry devices. You have the off-road Reentry catheter by Boston, the Outback, and they all use some form of needle technology. And you can see the needle technology is used here, both in the Outback or the Pioneer, which uses an IBIS or an Entier catheter. Next, please. So the other thing is use angiographic clues. You know, Vishal talked a little bit about using, calcification and other things. And you can see here you have a classic CLI case that we did here a couple of years ago, massive medial calcification. We actually were able to wire down using the calcification, using very little dye, and did a prolonged atherectomy balloon angioplasty and was able to get this done. Next, please. So again, sometimes breaking the cat, don't be hesitant to use laser catheters. If you try hard to break the proximal cap to enter, you can use the laser to go ahead and soften up the catheter, the plaque, and try to penetrate that way. Next, please. So other alternatives also is important, is that you might want to try different accesses. Popliteal access, you might have to try transcollateral crossing, retrograde pedal access, using ultrasound or angio. Next, please. So this is a classic example of a patient who had a 78-year-old woman presents with non-healing ulcer of the left ankle, medial history, hypertension, CAD, EF of 28%, diabetes, hypertension, dyslipidemia, and she had a CTO of the SFA. Next, please. So you can see here next. So you can see here that the iliacs were fine next. You can see here that you didn't see that she had an osteal SFA occlusion and that we couldn't get through, and then she had a popliteal next. So here, you can see she had an osteal SFA occlusion with no cap whatsoever. Next. So there you see again, it's flush occlusion. Next. So what we decided to do here is we did this live, I think, a few years ago. We got popliteal access next. Then we went ahead, you can see two views trying to enter the popliteal artery next. Then once we enter the popliteal artery, we inject to show that we're in place. Next. Go ahead, take a shot distally to show our distal lumen. Next. Then go ahead, wire. Next. Balloon angioplasty. Next. Next. Balloon angioplasty. So we crossed from below, snared the wire, did an angioscope. Next. and then we went ahead and placed the stent. And you can see here that we were able to resolve her rest pain. Next. So we went ahead, pulled out the, we used the Silver PTX from above. Next. And then we went ahead, pulled out the sheath. Next. And the patient healed her ulcer. Next. Next again. There you can see the distal runoff. Next. So so that's an example of using a retrograde access through the popliteal. So there's another guy with non-healing ulcer, low EF, occluded SFA, had prior attempt at an outside hospital and was turned down for surgery because of his EF. Next. So he had a horrible ulcer in his foot. So next. So we decided not to get retrograde access because the access points were involved with the ulcer. Next. So we went ahead, crossed up and over. Next. So you can see he has flush occlusion of the SFA, and you can see here he has 2 vessel runoff to the foot with really a very, very robust posterior tibial, which is where the ulcer was involving. Next. So we looked at him very carefully, and we saw that he had this robust trans SFA collateral. Next. So we went ahead, we approached the collateral. Next. We failed the regular way. We approached the collateral. Through the collateral, we put a 018 Trailblazer, and we used a 018, why is my pressure so low? An 018, this one. Next. Cycler cuff, guys. Next. So you can see we were able to cross from below. Next. Next, you can see the collateralization being very well shown. So you can see we're crossing through the collateral. Next. And then we crossed above. Next. There's our 018 quick cross. Next. They can see the angioplasty from above after we snared the wire. And then we did a DCB. And then we did a Silver PTX. Next. So you can see that these patients can do really well depending on how you decide to do it. Next. Next. So in conclusion, you know, we could keep going on and on with cases. Come back to me, guys. I think it's important for you to really study the lesion anatomy and really try to understand what is the technique that you're going to use in order to be able to cross these lesions. So right now we're doing DCB in the case. Next. Okay, can you see where the sheath is, guys? Is it because of the sheath?
No, I think we gave her some sedation.
You gave her sedation, Liz?
Sleeping.
Oh, okay.
She's totally nice.
Go up with the DCB.
I took pictures after the.
So Karthik took some pictures after the DCB, after the atherectomy.
Without predilatation. Oh, one second.
You can just go up without watching it. All fluoro, please.
Just go for.
Just go up to 6. So you can see here, this is after atherectomy. So you can see we have nice flow, but we have some dissection that we're going to have to take care of. Next, please. And now you can see that's the area of dissection up top. And distally, you can see you have that area of reentry that likely needs to be stented. Next. Okay, go up now. So now we're just going to go do a DCB and a stent. So it's been exactly, we started her at 8:15. It's been exactly an hour for us to do this case. And obviously, we've been yapping real fast. Literally, you should be able to do this case in 30, 35 minutes.
So for stenting, what are the options you're looking at from this clinical perspective?
I mean, Vishal, I think in this case, I mean, if you can get away, if you don't have a flow-limiting dissection, you could just get away with a DCB. I may just do that. You know, I'm just going to try to see what's going on with the after the DCB and see how it looks.
So let's say you decide to do a stenting. Since you've already done a DCB, is there a benefit of using silver over a bare metal stent, or is it the same, or I guess we don't know?
I think the answer is we don't know. Forgive me, I'm sitting down because I feel really weak. The answer is, you know, this is what happens when Karthik and Vishal beat you up all the time. The answer is I think we don't know, Vishal, don't you think? I think that ideally speaking, you and I would probably use a bare metal stent before we use a drug-coated stent after we use DCB. I don't know, Karthik, what are your thoughts?
I never use a silver after DCB. I am always concerned about more near-intimal drug release, and I'm concerned about pockets of aneurysm formation. We have seen it in coronaries. We know that, you know, when you use more and more drug-eluting stents and everything, you see some kind of coronary aneurysmal formation behind the stent. I'm always concerned about more near infiltration. So I don't know, PK, is that a more amount of drug?
I don't know.
infiltration into the system?
I think the truth is jury's out. I don't know. I don't think that drug-coated. I don't know, Vishal, whether you know of this, whether they've been associated with increase. As far as my knowledge, they have not been increased with aneurysm formation. I think that they are very safe. I just think that we don't know whether it adds any incremental benefit for you to go ahead and use a drug DES after a DCB unless there's flow limitation.
I agree. I mean, there is no real data to suggest
2 minutes
if
now.
anything would happen with using a DES over a DCB, because the toxicity of paclitaxel is almost at 250 mics, and we here is like 2 mics per millimeter square. So I don't think it really makes a big difference. But
So
it's more of a clinical judgment to see how you want to use things.
Right. So Vishal, what are your thoughts on distal embolization with DCB in a patient with true CLI?
It's always a concerning factor in your DCB use and distal embolization, especially in patients with CLI, because then you have to, because you want to have good inflow and outflow both. So if you create an outflow issue with distal embolization, then you have to go in, do aspiration, or do other maneuvers to make sure we reestablish flow back to its baseline, or at least improve the flow down there. So that's always a concerning factor. That's why I'm a big proponent of using a filter with most of these SFAs, CTOs, thrombus, or even if you're doing just plain old atherectomy, unless it's a very focal lesion, I really do use filters. And like I'm sure, like you've taught all of us to, before removing the filter, always assess to see how much material is in the filter, and if it needs any aspiration before you actually collapse your filter into the lumen. So.
Excuse me. I agree with you there, Vishal. But I think I'm asking specifically about embolization of drug. That's what I agree with you. You're absolutely right. Anything can embolize in these cases, and I think it's a disaster when it does, you know, meaning plaque or thrombus or whatever. But I think that what I'm really specifically concerned about do you have a concern about using DCB in patients with CLI based on the old impact deep data, which, as we know, is not the current impact balloon, is a completely different formulation, is not even on the market. We know that there's a lot of talk about this in conferences. So that's why I'm asking for us, you know, we have about 2,000-3,000 people who watch this every month. And, you know, what are your thoughts? Because I know I'm pretty strong on that. I'm just curious on what you feel. And
I think that's a very good point, especially the data below the knee has been controversial. I think that's how we should put it. And there are, I think, 3 trials going on as of now to really determine if DCB works below the knee. So the question is, as of now, we're not using it because it's not been approved, and the trial is not really that in a favorable direction. But I'm sure, hopefully, with like you said, change in balloon technology and using a medication and tweaking that up, hopefully we'll get better results and better answers to DCB. So right now, you're right; it's always a concern. So we'll keep it all above the knee and not try to go really below the knee.
But I think in Karthik, what about you? Are you concerned about doing? Maybe I should rephrase my question a little bit more, Vishal. Are you concerned about doing SFA lesions with the DCB in a patient with CLI?
I'm comfortable with it.
Yeah,
I'm comfortable because I think drug embolization is probably not a major concern here, even though the data of intrapopliteal has been so bad for DCBs.
Right.
But I think I'm very comfortable using.
Well, I think both of you have covered all the bases. I just want to talk about a little bit of data that was presented in TCT. It was actually a Medtronic in-house study using a porcine model, and I know that it's a healthy porcine model, and a porcine model by no means really looks at CLI the way the CLI microvasculature is. So what they did was they actually induced lesions, and they by actually having punch biopsies, for lack of a better word, in these pigs. And then they went ahead and did a drug-coated balloon, and then they looked at the time for wound healing, and then they sacrificed the pigs, and they actually looked at deposition of paclitaxel. So what they found was there was no delay in wound healing. The wounds healed, but what they did find was that there was embolization of paclitaxel, although paclitaxel did not impact wound healing adversely in this porcine model, non-CLI, true life kind of scenario. So I think the buildup of science starts with that, and I think that we using these type of lesions, these type of drugs, balloons in these type of cases, I think answers a lot of questions. I think we need to publish our data here at Sinai, because I know we've done quite a few of CLI patients with DCB. So we do have some data. The second thing, obviously, Vishal, as you know, the below-knee trial with Bard has come to a 6-month outcome in terms of, it should be done very soon and should be presented soon. So hopefully we get some good news regarding DCB and CLI. So I think we have to do one more balloon.
Yeah, PK and Vishal, question for below knee, right, PK? If you think the vessel is more than 4O size, would you be comfortable using a DCB in a below knee vessel, like a TP trunk or something, and it's one vessel?
I mean, I think we use off-label use at here at Sinai. We do that when we believe it's beneficial to the patient. So yeah, I think the answer is
so
yes.
What do you think?
Yeah, I mean, I agree. We all use it off-label. I mean, if it's a good size TP trunk, at least a 4O, you always have to be conservative to make sure you don't dissect at the TP level, because then it becomes a real issue, especially in CLI patients. So yes, if it's a bigger vessel size, and we do use it sometimes using DCBs, yes.
I have used it in some of the CLI patients, and they have been really doing very well.
That's awesome.
They have been doing really well, especially the vessel size is more than 4O.
Right.
They've been doing really well.
So what we're going to do is we're going to do one more balloon angioplasty. It's 9:20. It's just an hour since we went live. So we're going to stop after this balloon angioplasty. Just to let you guys know what we're going to do is we're going to put a regular stent. After I take the picture, we'll discuss where we're going to put the stent. Likely we're going to use spot stents versus long SFA stents. That's kind of been our philosophy here at Sinai, to use spot stenting. After which we will obviously send this patient home on dual antiplatelet therapy. The current recommendations are for 1 month using DCB, but generally speaking, we tend to put them home for 3 months, although we don't have any data to support that. Especially if they have Zilver PTX, obviously that data is for 3 months. So right now you can see here, Karthik is going to go ahead and inflate the final balloon here for the next 2 minutes. And I'm just curious on how would you guys decide on the type of stent? Supera, obviously we said DES we wouldn't do. Supera versus bare metal nitinol stent.
Well, we're going to ask you that question, but in calcified lesions like these, and if you have good luminal gain with pre-dilatation with the balloon, I'm a proponent of using Supera, especially with the data of Supera in calcified lesions. So for me, Supera would be a stent of choice in this case. I mean, there's nothing wrong in going with the nitinol self-expanding stent, like I said, if you have good luminal gain, but for keeping in mind the calcification, and especially if you're approaching the adductor canal, then Supera would work better in my own personal opinion.
Karthik, is there any preference in your mind?
No, because I mean, it depends on the location. If the focal dissection is in the proximal SFA, I don't mind using a regular small nitinol stents, because the patency of any nitinol stent less than 60 millimeters is great. If it's in the adductor canal, then I would probably go with the Supera, because the patency is very good. If I don't do a DCB after atherectomy, if I feel like there's a lot of dissection, I would just directly go with the Zilver, because it's great. The data is very good. So.
Okay. The other question I wanted to ask you is, in terms of, are there any regions that you guys would not use a Supera for everybody at home?
So I don't have any particular region where I don't use a Supera. I think we can use Supera any region, especially at flexion points. It's great, but I have never.
Well, my biggest concern is if it's more proximal SFAs, because Supera, you can expand, elongate, constrict. So if you're way at the proximal or the ostial SFA, I mean, unless you're very good and you have good control over the stent and size it well, you can sometimes extend it into the common femoral, or have some issues with that. So if you have to do a ostial spot stenting, then I would probably prefer a self-expanding or a stent more than a Supera in that case. That's again.
So I want to throw something out there. Would any of you have done a covered stent in this case rather than do everything we've done? I mean, you did atherectomy, Karthik. You did. So if you talk about cost analysis, so there's the 250 millimeter, Viabahn.
Mm-hmm.
So you see, the lady's got 2 vessel runoff to the foot, probably 3. We don't know. And you could have done 1 Viabahn for say $4,000 or $5,000. You did atherectomy and 3 DCBs plus minus stent. So your atherectomy is around $1,000, $2,000, or $3,000. Then you've got three DCBs, which are another 1,000 each, and then you've got a stent, which is say 600 each. So why would you not use just a 1 Viabahn to cover the whole thing?
I am not a covered stent guy. I don't know, Vishal. I'm sure you are not too. I'm not a covered stent guy in SFA, so I never use covered stents unless it's like a last option. I feel like once you use a covered stent, your options for further revascularization are so limited. You don't. I use covered stent only as a last option, and after covered stent, the only next option I feel is just bypass.
Well, you know, go ahead, Vishal. I'm sorry.
No, I guess, I mean, there's nothing wrong if you
Just the
really go by the
bypass.
clinical trials of using covered stents, especially in SFA occluded or calcified lesions, where I think the average patency rate is approximately 74%. So you could use that if you really go just purely by the finances, but keeping in mind patency, what we usually look at, and in patients who have CLI or ulcer, then the DCBs and these newer technology stents do prove the same stuff. So with covered stents, you could have issue with deployment, thrombosis, distal edge, knot apposition, and all those things. So I guess it's more of a clinical perspective. But from data point of view, there's nothing wrong in one or the other.
And I agree with that. I think that it obviously you have to follow these patients closely. They have obviously candy wrapper edge restenosis. You may want to, if you have a drop in pressure, then you definitely want to watch these very carefully. So now we've given some nipride. The pressure is going to drop a little bit, and obviously we're worried about that filter because, like I said, we might have embolized. So now you can see, yes, we did embolize. You can see there's no flow. So we'll now take a look. It just gets a little better for us every moment. Let's take a picture. Okay, ready?
Just waiting for the pressure to lift up a little bit.
I think it's all because of crud in the filter right now. Let's take a shot though. Nope, I was wrong. And see, this is a very acceptable DCB result to me.
Yeah.
See, I mean, unless there's anything anybody really sees, go next, please.
There's
Some lower.
some dissection in the mid, which we expected.
I mean, Tom Zeller would not stent this. I can tell you that. Tom would say, leave it, you'll be fine. Inject. Maybe that distal spot you can stent. Yeah, I would stent the distal spot. So we're probably going to put one Supera for all of us at home, and then we're going to be done. We're going to be out of here. So I'm just going to wrap up now, Vishal, if you don't mind, and Karthik. So I think this case really showed a lot. You can see the wonderful 3-vessel runoff now to the foot, which I think is awesome, and I think it'll open right up. Yeah. So I think so. What we're going to do now is, this case demonstrated all the nuances of a CTO. Obviously, you learned about the different wires and learning from both, first of all, the angiographic anatomy as well as the angiographic clues to help you cross. We talked about different technologies and different wires and went over some different strategies. And I think we basically hit every important point on the head, including different access points and different modalities of crossing and CTO devices. So it's exactly 9:30, about an hour and 15 minutes after we started. So I really appreciate you guys for joining in on us. Have a happy holiday and a happy new year. I'd like to welcome Marichu, who decided to join us today. So thank you again. Thanks, Vishal.
Thank
Happy
you.
New Year, guys.
Thank you very much, PK and the team. Thank you, everyone, for joining us for another interesting live case from Mount Sinai Hospital. Just to wrap up, this case will be available on the website by the end of the week. You can go to peripheраlinterventions.org and go on the archive section to see any of our previous live cases from last year or years before. Please do join us next month on January 20th for another live presentation. In the meantime, have a happy, safe holidays, Merry Christmas, Happy New Year. Thank you for joining us.